Hi, good morning, everybody. I think it will be a very interesting and a really, really important session. I'm very much looking forward to it. We always say that science has sense if it's going back finally for community benefits. I think it's a typical issue when we have currently lots of knowledge in genetic part. We learned a lot from the biochemical studies as well. And now the question is how we can translate it back to community benefits, not with harm, without harm. So I think this will be a very interesting question, especially for me as a clinician, who is almost every day get a question from the patients that one of my relatives has a genetic risk, what to do, should I test myself, shouldn't, whether this will affect about the severity of the disorder, whatever. So there is lots of questions from the clinician side. So I can't wait really more to hear actually the presentation. So we will have two presentations today. One of them will be from Mark Lowe, the other from Rubjedi Talukdar. Both of them are internationally highly known people. I may ask Miklos to introduce a little bit Mark, the first speaker, and after we can hear during the presentation who should get genetic testing, what to test, and when to retest.
Thank you, Peter, and welcome everybody. And it's a pleasure to introduce longtime friend and collaborator Mark Lowe from Washington University, St. Louis. Mark is a professor of pediatrics, and he is also a passionate basic scientist in the area of lipases. So we asked him to talk about why should we test, who should we test, when should we retest, and anything and everything about genetic testing. Mark, it's a pleasure.
All right, thank you. And thank to the survivors who are still here, appreciate it. And thanks to the organization for inviting me and giving me a chance to talk today. And as Miklos mentioned, I've been assigned the task of who should have genetic testing, what to test, and when to retest. My disclosures are here, but perhaps the most important disclosure is I'm not a genetic counselor. So this is an area that I'm aware of. We do talk to our patients all the time about genetics, but I'm not actually a counselor. So as everyone here, I think, really knows, genetics are important in pancreatitis. There have been linkage studies that have identified genes associated with chronic pancreatitis. Some of them are Mendelian. We've heard about them. I've listed two here. There are probably others. PRSS1, which is autosomal dominant, CEL, which is also autosomal dominant. But most of the genetic variants, risk variants, are not Mendelian. They're really, as I said, genetic risk variants. They're enriched in affected individuals, but they probably don't cause disease in isolation. And this has led to the concept that we're all familiar with, that pancreatitis is a complex disorder, and it's not easily explained in clinical pathological disorders or Mendelian genetics. And there are other factors. So there seemed to be an interaction between environmental stressors or combinations of genetic risk variants that oftentimes lead to the outcomes of acute recurrent pancreatitis and chronic pancreatitis in our patients. So this is an edited list of who should be considered for genetic testing. There's other reasons that are given, but I've not included those. So people who have recurrent attacks of acute pancreatitis for which there is no identifiable cause should be tested. And some of you may be thinking, well, I just said that this is a complex disorder. So why wouldn't you, somebody who has an identifiable cause, why wouldn't you do genetics on them to see if there's some interplay? And I think at this point in time, clinically, that's not useful. And that this is doing genetics on people that are identifiable causes are appropriate for the last bullet. So patients that are in approved research protocols could get genetic testing if they have, a congenital anomaly, for instance, that increases their risk, or they have gallstones that increase their risk. So patients with recurrent attacks of acute pancreatitis should be tested. We'll talk some more about that. Patients who have idiopathic chronic pancreatitis where no etiology has been identified and have not had genetic testing. If there's a family history of recurrent pancreatitis or idiopathic chronic pancreatitis, genetic testing is likely warranted. Particularly if there are relatives known to carry mutations associated with hereditary pancreatitis. And there's a class of patients that puts in their yellow category that may have chronic pancreatitis, and sometimes this genetic testing may help you sort out or provide more evidence that they are likely to have chronic pancreatitis or do have chronic pancreatitis. And as I've already mentioned, any patients that are eligible for approved research protocols is maybe another indication for genetic testing. So as I said, recurrent attacks of acute pancreatitis for which there's no identifiable cause. And I think the data suggests that the pretest probability of getting a positive result or identifying a gene is very high. And this is shown in this graph, which shows the percent of subjects with genetic risk variants in children and in adults. This is from the INSPIRE and NAPS2 studies. And in children, almost 60%, and that number has varied a little bit each time we look at our populations, but it's going to be in that range and perhaps a little bit higher. So many children have genetic risk variants that can be identified. So that's may be quite important in children, but also adults. It may be up to 20%. And the difference in adults is that now in the NAPS2 study, they've sequenced everyone. So this is probably a pretty good estimate, but it may be higher, maybe a little bit lower. But even, a pretest probability of 20% is probably higher than almost any other testing that we do on our patients. So this is a very important group to consider genetic testing. In patients who have chronic pancreatitis, whether it's idiopathic or not, you also have a high number of subjects that have genetic risk variants. So in children, it may be as high as 70% if they already have chronic pancreatitis. Adults, it's once again a 20% range. But if an adult presented as a child, their risk is close to 80%. In the NAPS2 studies. So this is another patient population, if you don't have another explanation, to consider genetic testing. So as I mentioned, relatives known to carry mutations associated with hereditary pancreatitis. And this is actually a family history of a family that I take care of. The grandfather of the two siblings on the had pancreatitis. He had relatives that had pancreatitis. The mother of the two children was actually a patient of mine at the time, and may have been one of the very first children identified with the PRSS1 R122H mutation. As soon as David published his paper, I used his the primers from that paper and sequenced this in my lab. And that time you could do those things without our IRB approval. No longer, but she had chronic the R122H mutation and had very significant disease. She did marry and had two children. And the younger of the two children was born with multiple congenital anomalies and was enrolled in a research study, the Undiagnosed Disease Network, which is a network in the United States that will try and identify genetic variants associated with diseases that don't have a diagnosis or don't have an etiology. And when they did this, they didn't find a good reason why she had the congenital anomalies, but they did identify that she had carried the R122H mutation. And when I first saw her, at that time, she was about a month old. And she had a 4-year-old daughter that had not been tested. And the 4-year-old daughter, about a year ago, had her first episode of acute pancreatitis. The family had not wanted her to be tested. We were tested at that time, and she does carry the R122H mutation. Fortunately, she had her second episode about a year later, and that turned out to be very complicated necrotizing pancreatitis. A section from her CT scan is shown here, that large dark circular thing. Off to the side next to the spleen is the pseudocyst at the time, and there was very little identifiable pancreatic tissue there. And she's still she's scheduled for a repeat ERCP on Monday, so she had a very bad risk. And if the patients had just chose to test her when the other one was known, we wouldn't have been able to do anything about this. We couldn't have stopped this. She actually had episodes, whether in visiting relatives in Chicago, got to the one of the children's hospitals there very quickly and received, standard care. Yet she had this very severe episode of acute pancreatitis. But genetic testing, I don't think would have changed that. So if you have possible chronic pancreatitis, again, I'm going to illustrate this with a patient that of my own. It was a 3-year-old female came with abdominal pain and abnormal stools. Mother described them as fatty. And at that time, she had normal growth. She was seen by another gastroenterologist who sent a fecal elastase that was less than 15. This has been repeated multiple times and has remained low. She had an elevated quantitative fecal fat with CFA about 60%, normal liver transaminases and bilirubin, and had a normal sweat test. Imaging showed that she had a mildly dilated common bile duct, but a very normal pancreas, including a normal pancreatic duct. After additional evaluations for possible etiologies, we did do genetic testing. We tested her for Shwachman-Diamond syndrome. There are no variants were identified. We also had genetic testing done. And in this example, she had a SPINK N34S variant. And now the question becomes, is that really significant? Does that help? And we know that 1% to 2% of people carry this. Most of them don't have pancreatic disease. So is that an important variant or not? And that becomes a difficult question. And this is not, if you look at patients who have SPINK1 mutations, and we've got a fair number of them in our database, this is not how they present. But it remains a question. So was that genetic testing helpful in deciding what is going on in this patient? She's had repeat imaging of her pancreas. It remains normal at this point in time. So had this been a stronger risk variant, one of the PRSS1, that it may have been helpful. I pushed the wrong button. Sorry about that. Thank you for pointing it out. Yeah, one person was awake. Yes, that's good. I like that. And these buttons are very sensitive. You notice? Yeah, okay. That's my excuse. So you have a choice of single gene analysis. So picking a specific gene that you might think be important. You can do multi-gene panels, or you can do comprehensive genome testing. So single gene testing, you should consider that if there's a family history or clinical findings that suggest multiple family members are affected. So we know that PRSS1 is autosomal dominant. We know that it has incomplete penetration, and there are pedigrees where it's skipped a generation. Oftentimes the onset of acute pancreatitis in childhood, but there are not other clinical things that are going to help you too much. The CFTR, the patient has had problems with sinusitis, nasal polyps, or male infertility, or other symptoms of CF-related disease. They oftentimes will have an indeterminate sweat test. So it may be appropriate just to do CFTR testing when you start the analysis of that patient. Carboxyl ester lipase deficiencies, which is fairly uncommon, and so far has been mostly found in Northern European populations. It can present as maturity onset of diabetes of youth. It can have unexplained exocrine pancreatic insufficiency, but pain and recurrent acute pancreatitis are generally not present in the patients who have these mutations. So that may be an indication to just do individual CEL testing. Typically with single gene testing, you would do sequence analysis first, and then perhaps gene targeted deletion duplication analysis, particularly with the PRSS1 variants. So as most things, as we take care of our patients, the good history and clinical findings are important in making this decision. Now, there are multiple companies that now offer multiple gene panels. And one should think about this when you don't have a reason to suspect a single gene, but the patient's fits one of the other categories for genetic testing. The genes included can vary from company to company. The company you use may depend on the lab that you send this blood sample to. You may not have a choice. Their analysis may differ. Some may do sequencing, some may do sequencing and deletion duplication. So it's important to know what's being offered. And they may include genes that are not necessarily associated with pancreatitis or have unclear association. You need to know something with that. The graph on the right side shows data from the Inspire 2 cohort with a % positive for risk variants. And one can see that the most commonly identified genes are PRSS1, CFTR, and SPINK1. So I think any panel you choose should probably include those. Many panels will include CTRC, some will include CPA1, and we do find a small number of patients with those variants. But we've also found some with the calcium sensing receptor variants and a calcium channel TRPV6 variants that may be associated with increased risk. But we're sequencing 18 genes in this research study, targeted genes. So most of them we are not finding in our patient population. As I said, I think you need at least the top 3, but most are offering a little bit more than that these days. Comprehensive gene testing, exome sequencing, genome sequencing are the options that we have. The American College of Medical Genetics recommends informed consent if you do this type of testing, and this may be a time to involve your geneticist or genetic counseling. Their criteria for the informed consent, you should have written documentation of the consent. Seems you shouldn't have to say that, but it happens. Discussion of possible significant incidental findings should be part of the discussion. So what if you find something that is unrelated to pancreatitis, but may be a risk variant for some other disease, particularly as they get older? To discussion of expected outcomes, once again with the incidental findings discussed. Potential benefits and risk, and in our case, this includes a discussion of that there's no therapeutic benefit. The argument's often made that it provides a likely etiology for the patient's disease and may stop additional testing or provide the family with more information. And now we are learning a little bit more about the natural history of some of the different variants. So you may be able to provide better counseling for the family. And if there should be a clear distinction between clinical and research testing, if that is the situation. And there should be a discussion of the future use of data, including whether it will be in a database and who will have access to that database. And it's very important to policies regarding recontact as new knowledge becomes available. We're learning more and more about the various different variants. Some that were thought to be benign may eventually turn out to be associated with increased risk. Some that we think have increased risks now may change with time. We're getting more and more data about the function of some of these variants, and so that may change. And so there should be some plan discussion of recontact. So when to consider retesting. So I've already talked about recontact or reanalysis when there's new evidence or about association of a variant of uncertain significance with pancreatitis or new evidence about its effect on function, which comes about. If there's been a large amount of time has lapsed since the last testing, there's continuous improvements in DNA sequencing technology, there's advancements in bioinformatics, and new risk variants are identified. So if it's been a while since that patient was tested, it should be some thought should be given to whether or not it's reasonable to retest. We still have some patients who clinically were tested with panels that included one or two variants. If there are additional patient phenotypes or family histories becomes known. So if you get a family history that there's, they all of a sudden discovered that there are multiple family members who've had pancreatitis or pancreatic cancer, that may be a cause to reconsider whether you should do retesting. And in this regard, it's often important to consider banking DNA. Now, not mostly that's done in the research setting, but it may become more widely available in the clinical setting. So thank you very much for your attention and being here this morning. And we'll take questions afterwards or when. Okay.
Thank you, Mark. So now it's a pleasure to introduce Rupjyoti Talukdar, who came all the way from Hyderabad, India. And then Rupjyoti is very active in genetic research, and then India has a large pancreatitis population. So this is the place to do genetics, and it's a pleasure to have you here today. Thank you.
I think I'm audible now. Very good morning, and thanks for coming in the early morning of a Sunday. How do I move the slides? Okay, yeah, got it. Yeah, so my job that has been assigned to me today is to speak on what's new in genetic risk variants and the clinical applications. I don't have any disclosure, though I have a disclaimer. I'm not a mainstream geneticist, so I won't dare to dwell upon the technical genetics in front of the master sitting besides me. So what I'm going to do today is to give you a clinical perspective, to bring out the clinical aspects of this genetics and pancreatitis, and then try to take the whole thing towards a discussion on how to put the whole genetic problems into the clinical perspective with the patients. So let me begin with the story of these identical twins. 33-year-old male who came to the pancreas clinic this couple of months back. So the first brother had a diagnosis of initially had recurrent acute pancreatitis in October 2010. While the second brother had the disease diagnosed in 2017 with a gap of 7 years. Both of them, the first brother had recurrent abdominal pain. Interestingly, the twin did not have any pain abdomen. He never had any acute pancreatitis or pain abdomen whatsoever. There were similar pancreatic ductal morphology with pancreatic atrophy, ductal dilatations, pancreatic ductal calculi. The first brother had a pancreas divisum. The second brother did not have a pancreas divisum. And in the first brother, diabetes was diagnosed 9 years after the onset of pain. And in the second brother, diabetes was diagnosed 1 year before the diagnosis of CP. So while evaluating for diabetes, he was found to have chronic pancreatitis. And both of them came rushing to the pancreas clinic with an exome report done elsewhere. We do not do exome on clinical patients for research protocol. We do for some patients, but he came with an exome report from somewhere else with a worry like, doctor, are we going to die soon? Can we get married? What is the future of my disease? So all those questions were there in their minds. So let's keep this envelope closed for some more time. And so if we go by the current concepts of genetics and chronic pancreatitis, so there are three well-defined pathways: the trypsin-dependent pathway, the misfolding dependent pathway, and the ductal pathway. And I won't go into the details of the genes. So just I have listed down the important pathogenic variant in the PRSS, SPINK1, PRSS2, which is usually a protective variant CTRC, and the inversion of the CTRB1 and 2. In the misfolding dependent pathway, again, there are a couple of PRSS1 variants, the CPA and the CEL variant. And in the ductal pathway, the CFTR is the most profound. Claudin MORC4 was discovered around 10 years back. Then we have the CASR, and the most recently discovered was the TRPV6, which is responsible for calcium signaling in the ducts. So there are a few other new variants actually very recently. This is a big list of authors who have discovered this gene called this CGPR6A variants. The functional analysis, I think, is still yet to be done, and it's not very clear how strongly it causes pancreatitis, but it has a potential role in calcium sensing receptor and the inflammation activation, especially in alcoholic chronic pancreatitis. So this could be an important risk variant. And more recently, the CUS-D1 gene had been discovered or had been studied in unrelated European and Japanese cohorts in patients with early onset CP with an age of onset of before the age of 20 years. So this gene is highly expressed in mice acinar cell and localized to the zymosin granule membrane. And mice deficient in this gene had been shown to develop severe pancreatitis. So this could be another important variant in the humans, which still requires study, and I'm sure they're working on that to make us understand better. Now, again, this most of you already know, especially in hereditary pancreatitis, the PRSS1 and trypsinogen story has been pretty well elucidated. If you see on the right-hand panel, the red arrow, so those variants are actually responsible for inhibiting or reducing the CTRC-mediated degradation of trypsinogen. And on the left panel, the upper three genes are usually responsible for upregulating the CTRC-mediated autoactivation. And the black-colored guys are responsible for autoactivation independent of CTRC. And this has been elegantly validated in functional animal models in several recent studies. And when we talk about the digestive enzyme, the other genes like CPA, the cell, and some of the PRSs, they are responsible for protein misfolding, which leads to ER stress, and ER stress eventually leads to pancreatitis. And on the other side, left side of the image, if you see the TRPV, CFTR, and CASR will cause disruption in the ductal calcium homeostasis that would lead to hyperacidity within the duct and lead to trypsin activation within the duct and therefore pancreatitis. So the role of CTRC has even been better and more powerfully elucidated recently in this meta-analysis when these three variants had been shown to confer significant risk up to the tune of 6.5 to 7 odds ratio in producing pancreatitis across different populations in the world, including India. And when all the homozygous and compound heterozygous variants were considered, the odds ratio was as high as 10.8 in imparting risk to these patients with pancreatitis. Now let us look at the global perspective. So whatever I was talking were about studies done from localized population, either in the Europe or Asia. So if you see here, this is the global perspective. Most of the studies have come from Europe, from the France, German cohort, Polish cohort, and some from Japan and Indian cohorts and Chinese, of course. But if we see here, I don't know if there is a marker. Yeah, okay. Yeah, there is a marker here. So if we see in Indian patients, especially the Southern Indian and Eastern Indian patients, we consistently see this variant in cathepsin B, which is not found in German cohort and other places in the world. And then again, we don't see in India the typical R122H polymorphism that is the most important risk factor for hereditary chronic pancreatitis. So that's a disparity between India and the other parts of the globe. Also, several pathogenic marker variants of the CASR are not seen in Europe as a whole. While the CUS-D has been seen in European cohorts, it is not seen in Indian cohort and also in Japanese cohort. The PNDIP gene variants are common in the Japanese cohort, but they are not seen in the other part of the cohort. So basically, this slide is to show that even though we have understood about the genetic polymorphism, but there are still discrepancy Across the globe, not all genes are seen in all the places. So what does it mean? Does it indicate that there could be some kind of other factors playing a role? So let's see what happens in terms of race. So in this study, based on the NAPS cohort, where the authors have looked at the PRSS, PINK, CFTR, and CTRC, and their comparison was done between the African ancestry and the European cohorts. There was significant tight clustering of the patients of European cohorts shown in the red area in that principal component analysis. But in the African ancestry cohort, there was wide heterogeneity. And if you notice the blue, colored dots there, that indicates these are the patients with genetic polymorphisms. So here again, that shows the disparity between the African ancestry cohort and the European cohort. So if we dwell a little bit deeper into this, in the first table, the comparison or analysis was done only on the African ancestry cohort, and what was found that there was no significant difference in the different gene in the different kind of pancreatitis, and majority of these patients were actually self-reported moderate to heavy drinking. And when the analysis was done between the African ancestry and the European cohort, there was significant increase in the frequency of genetic polymorphisms in the patients in the European cohort. So overall, 29% versus 18.8% difference was seen in this patient with an odds ratio of 4.6. There was difference in all the genes except the CTRC. So this again possibly points towards something more than the gene. So is there an environmental interaction? Because the African American cohort had a history of alcohol intake. So this study comes from China, where they had studied the impact of genetic and environmental factors in the progression of chronic pancreatitis. So a decent sample size of nearly 800, follow-up period was pretty long for 10 years. And majority of these patients had idiopathic chronic pancreatitis. There were smokers and people who took alcohol. And they looked at the SPINK, PRSS, CTRC, and the CFTR polymorphisms. And what they did was they divided the patients into 4 groups: those who had a genetic risk factor and alcohol and environmental risk factor in the form of alcohol and smoking, who would have only one of the risk factors, and who did not have both the factors, environmental risk factor and genetics. So what they could showed was if the patient had environmental risk factor and no genetic risk factor, or both the genetic and environmental risk factor, there was significant increase in the progression of significant rapid progression of chronic pancreatitis. The only thing here, they define progression of chronic pancreatitis with the development of pancreatic exocrine insufficiency. Probably inclusion of other parameters of chronic pancreatitis would have given a more powerful data, but nevertheless, it shows the strong possibility of a gene-environmental interaction in these patients. And then pancreas divisum, that has been a age-old contention. Is pancreas divisum a cause of pancreatitis? Is it not? And I think Dr. Pramod Garg, who's in the crowd today, was one of the first to show increased prevalence of genetic polymorphisms in patients with pancreas divisum, which kinds of points was there could be an association of these two factors. And that was followed by other studies where the PRSS PINK genes, CFTR polymorphisms were shown to be present in a higher frequency in patients with pancreatitis and with pancreas divisum. And we had conducted this study after that, where we could show that the patients who had pancreas divisum and idiopathic recurrent and acute pancreatitis, the presence of the cathepsin B polymorphism increased the risk of recurrent pancreatitis by almost 4-fold. So this again shows the importance of gene-environment interaction in these patients. And outside of the hereditary pancreatitis population, this could be an important interactive event going on, which leads to the progression of the disease and maybe initiation of the disease. Now, what about gene-gene interaction? Again, we have seen from Dr. Lewis talk, and I'm sure most of you have seen this clinically, a patient who comes with a panel of genes. There will be several different genetic variants present. So this was a GWAS from India. Again, Dr. Garg was involved. If you see here, with the number of increase or with the increase in the genetic, with an increase in the risk allele number, the risk increase, the risk of the odds ratio of developing chronic pancreatitis increased. And then there has been several studies which do talk about gene-gene interaction. For example, these are just some examples. There are many more. Patients who are heterozygote for SPINK1 and CFTR with one variant in one of the alleles and one variant of the CFTR in another allele. So there is a 60-fold increased risk of chronic pancreatitis. If the patient has a compound heterozygote for CFTR and a SPINK variant in one of the allele, they have even higher 900-fold increased risk of pancreatitis. Again, there could be synergistic effect if the patient has both the CFTR and SPINK. If the patient has both SPINK and CTRC trans heterozygosity, they could have an additive or multiplicative risk, both of them being in the same mechanistic pathway. Again, trans heterozygosity of TRPV and CFTR can lead to additive effect being in the same pathogenic pathway. And again, synergistic effect can be seen if the patient has a TRPV6 and SPINK1 trans heterozygosity. And then what about drugs? Now, it's a good news for the CFTR patients that the modulators have come who have improved the quality of life by changing their disease biology. And many of these patients do have recurrent acute pancreatitis. So is there any benefit of these modulators in these patients? So there has been a couple of studies, and I have collected this this table from one of the reviews. And if you see the patients who are pancreas sufficient cystic fibrosis, the modulators have resulted in a decrease in the risk of the frequency of the recurrent acute pancreatitis. They have the patients who are insufficient has become pancreas sufficient, and there is a benefit. But the flip side is there are 4 or 5 case reports which showed that many of these patients can develop a recurrent acute pancreatitis after the modulator therapy. But if you see carefully, these patients are pancreas insufficient. And in these patients, when you give this modulator, the pancreas insufficiency converts to pancreas sufficiency, that probably increases them to the risk of recurrent pancreatitis. Probably there could be some other genes sitting in these patients which may be reducing the threshold of the recurrence. And thus the variant impact disease progression. Again, this is a study from Cincinnati, over 100 children, 54 acute pancreatitis, 31 acute recurrent pancreatitis, and 26 chronic pancreatitis. Most frequent etiology was genetic, followed by divisum, trauma, metabolic, biliary, and the genes CASR, CFTR, CPA, CTR, SPINK were evaluated. And if you see the first 3 panel, whenever there was a in genetic polymorphism, there was a significant increase in the rate of progression of the disease. And as the number of polymorphism increased, if there were more than one polymorphism, it had a most rapid progression of the disease compared to one polymorphism compared to no polymorphisms. So this again clearly tells us that this would be probably the beauty of doing a genetic testing for children with recurrent acute pancreatitis, and based on the number, we could probably predict the progression of the disease. So coming back to the identical twins, this was what was in the envelope. And if you see here, there are 3 pathogenic variants common to both the brothers. There are many other benign variants that were common, and there were 3 genes that were different in both the brothers. And we still find it difficult to understand why one had recurrent pain while the other did not have pain. There was pancreas divisum in the first brother and no divisum in the second brother. So it's difficult to explain the complex conundrum why this is happening. So why did I say all these things? Why did I bring up the different aspects of genetics and pancreatitis, the global aspect, the racial aspect, progression? So So based on this, and this is where I'd leave you today with more questions than answers. So how to personalize genetic testing in the midst of this heterogeneity? And Dr. Lowe had brilliantly shown some of the indications where this can be done. But now again, should we go for specific gene panels? So these are the several questions that we need to answer. Should we do it for all patients? Or idiopathic recurrent acute pancreatitis or idiopathic chronic pancreatitis, only children or young adults or all? Do we go for a candidate gene? Do we go for a whole gene exome? And how to put in the environmental factors in this whole arithmetic. So I leave you here and would be happy to take questions. Thank you.
Please come up. Fantastic talks, and I please ask questions. And I'd really like to hear some comments. You know, how would you use genetic testing in your clinical practice, and what would be even more useful? How the field should move forward? Because both speakers highlighted the complexities of genetic testing, and particularly when it comes to interpretation. Please, Chris.
Those are both terrific talks. Thank you. I mean, I was wondering, so I see a lot of patients in clinic who come in with unexplained chronic pancreatitis or unexplained relapsing acute pancreatitis. And typically they've been labeled as being alcoholic or something like that. And so when I see those folks, I'm often doing genetic testing kind of right off the bat because everybody's eliminated the other possibilities. And I get a bunch of these folks with CFTR mutations. And then I do the sweat chloride afterwards, I think most people might think about doing it in the reverse order. But is there a way in those folks? I mean, let's say I find a CFTR mutation or 2 or 3, and I want to know if I should try them on ivacaftor or one of these agents. I was just wondering if you could help me figure out what to do with that information. So I know they have a gene mutation. I know they have relapsing pancreatitis, and I'm deciding whether I can do anything about it. What's the strategy?
Yeah, so I think the CFTR is probably one of the tougher ones. There are so many variants. And if you have a variant that has a strong association with, or an association with acute recurrent pancreatitis or chronic pancreatitis, and also has a known effect on function, then I think the likelihood that that plays a role in the pathophysiology is high. And so it's useful. Now, should you start as a corrector? I think the insurance companies will probably answer that question for you as no. I think it's unclear. There's not been a clear study that shows broad effect in patients who have pancreatitis and have a CFTR variant. That type of study needs to be done. There have been indications. There are also a few case reports of folks who were put on correctors and developed more severe pancreatitis. So I think the safety profile is still unclear, although I'm pretty optimistic about it. And there are people who do, when they can convince the insurance companies to pay for it, put people on correctors.
I think it was I also have a comment on it. It's a brilliant question. Actually, what we have shown earlier, not also in basic research, but also in human, that those factors, for example, like alcohol, also like decrease the activity of CFTR. So, for example, the sweat chloride concentration elevates in those patients who's drinking alcohol versus who does not. So actually, if we have a population with chronic pancreatitis and you say we are uncertain about the etiology, maybe yes, whether if somebody drink only 1 glass of wine, should we think about that this is alcohol or not? We say very, very quickly for the patients, unfortunately, that they have alcohol-induced chronic pancreatitis. So I think I can see clinical benefits if there is a patient and maybe with the CFTR mutations and they get the information that, okay, you have these genetic mutations, we cannot do anything about it, but there is clear evidence that those factors even further decrease the activity of your channel, and most probably the progression of the disease will be very, very high. So I think it's a very, very good questions. I think lots of research is needed, who to test, and also what to do with the information what we tested.
Thank you, Balázs.
My name is Balázs Németh, University of Szeged, Hungary. Thank you very much for the very nice and informative talks. My question would be that, is there any age limit? What do you think until when we should test patients with idiopathic chronic pancreatitis?
Yeah, so yeah, it's an interesting question. Certainly, I think that anybody who presents below the age of 18, we should be considered for genetic testing. If they present at an older age, I think it depends on the clinical situation.
Okay, thank you. Next
Hi,
question.
Torah International America. My name is Kim Anjong. I have a question about is there any pancreatic exocrine function blood markers in the world? And if the answer is no, will it be helpful if there is a simple blood marker to can measure exocrine function to treat patients?
That would be wonderful. But I don't know of one that is proven to be useful yet. There's a lot of interest in trying to find one, but there's nothing yet that I think is even that promising.
Excellent. Vikesh Singh, Johns Hopkins, excellent talks. I have a couple of questions, maybe a few comments, but one of the things I think it's important to remember is when we talk about using CFTR modulators, while they're only FDA approved for patients who meet criteria for cystic fibrosis, I think the question really is can we start to think about using them in really two groups of patients, specifically because of heightened risk of acute recurrent pancreatitis, and who we're talking about are pancreas sufficient CF patients, and then patients who have CFTR-RD, right? Their sweat chloride never goes above 60. They don't have any other CF disease manifestations. They don't have a second allele implicated, a CF causing mutation. So really, would there be a role for using CFTR modulators in this population? And because this has garnered some interest, and there are some companies that are working specifically on using correctors that might only correct the function a little bit, because that may be just enough to keep these patients from having recurrent acute pancreatitis. The second point, or it's more of a point, is pancreas insufficient CF patients who are given modulators. They don't actually convert to sufficiency. If you look at the data, if you go by fecal elastase levels, very few actually did come back up into a range that would be consistent with pancreas sufficiency. So what that suggests to me is the ones who are getting pancreatitis must have just enough acinar cell reserve to mount an inflammatory response. And again, this has only been reported in a couple of case series. I think the largest published
4 or
today
5 cases
is 5, right? And the last thing I wanted to ask, and it wasn't brought up, and I think it's sort of the the elephant in the closet, particularly in terms of how genetic recurrent acute and chronic pancreatitis is being treated in the United States, is the use of total pancreatectomy and islet autotransplantation of these patients. I just kind of want what folks' thoughts are on this, because Dr. Bellin's here in the audience. We have a lot of site investigators for the post study here, and we're about to report 6 years of data on looking at TPIAT in patients predominantly with genetic disease. In fact, a lot of our centers have stopped doing it in alcoholics and smokers and other causes of CP. So what are your thoughts on that as well?
That's a brilliant one. I would touch the first two questions concerning the CFTR. We just get a big systematic understanding about those patients who had CF mutations and has pancreatic exocrine either insufficiency or recidive pancreatitis. And of course, there is only case reports and small cohorts, but it's very, very clear that these patients, whenever they got, for example, Orkambi, during the period of the treatment, none of them get recidive pancreatitis, none of them. And the inclusion criteria was to have at least 1 or 2 attacks in the last 12 months before the therapy started. And this is very, very important point. On the other hand, of course, there is contradictory, but still there were patients among in these cohorts which actually had pancreatic exocrine insufficiency, and they started the Orkambi therapy, and after the elastase concentration elevated. Of course, whether how long could it be kept, it's a question, but there is really a hope, I think, that those patients who has CFTR mutations can get benefits. Unfortunately, or on the other hand, it seems more than likely, but not only those patients may get benefits who have mutations, but if one of the toxic factors, for example, strongly inhibiting CFTR. So now we are at the preclinical phase with animal models when we induce alcohol or fatty acid induced pancreatitis, and we're giving back Orkambi for these animals, and actually the severity of this pancreatitis decreasing. So I think the CFTR part is really very important, both from the genetic side and both from the environmental side.
Yeah, I would I totally agree with that, but I think we definitely need studies to guide that therapy. And it may well be that there are subpopulations, for instance, that are more likely to benefit, or subpopulations that are more likely to have adverse events. I think we all know that the history of medicine is littered with therapies that have been tried, but only to be shown to be non-efficacious in clinical studies. So I think that's important. And this is a clear area that I think an obvious target. With TPIT, I've said before at this meeting that I would like to make those surgeons much less busy. And so any medical therapies that we can do to try and interrupt the progression from the first episode of acute pancreatitis to chronic pancreatitis should be our goal.
Pramod Garg from New Delhi. Very nice talks. Arup, my question to you is, you showed that map of genetic variation differences across the globe. What do you think is the likely cause? Population migration, founder effect, and Miklos could also answer that.
So I think one could be the ethnicity driven, and population migration could definitely have, if you see in the American African descent, so there were few patients that were heterogeneous, but many of them had migrated, and there were admixtures with the European or Caucasian cohort. So I think we're correct. It might be one of the reasons could be migration, and the other could be the descent, genetic descent of or the ancestry, and that drives the heterogeneity.
Right. So for example, in India, the SPINK1 N34S is about 35 to 40%.
Yeah.
While in rest of the world, I think it is much lower.
Yeah.
So Miklos, your thoughts on that? SPINK1 is about 35 to 40% in India, and rest of the world is about, say, max 15 to 16%. And consistently, these are the reports from India. So what do you think is the likely cause? Some kind of founder effect, or
difficult to say, because in that population, so in India, we don't have that much of migration or mixture, I mean, in the people whom we're talking about. So maybe if you have some thoughts on that.
No, don't know. It's a very, very interesting question. Yeah. But I think regional and ethnic variations are important when we do research studies and we try to interpret the data. Because often, particularly in the US cohorts, it's really hard to know that the differences we see are just due to the different population mix they are testing.
Had to rise after Mark's last comment. I would love to be, as a surgeon whacking out lots of pancreases every year, I would love to be much less busy. to go off on something that Marcus Lurch mentioned yesterday that requires us to be able to diagnose pancreatitis much earlier before it's end stage, which is when I'm whacking out their pancreases, and to have some sort of effective therapy to interrupt the pancreatitis. And I would love to be made much less busy when we have those things happening. Thank you.
Oh, sorry.
Oh,
After you.
Minotti.
No, I was thinking about those poor twins that Roop was talking about. So, obviously the idea would be to try and prevent recurrent acute attacks for them. What will you do? Because they probably are not heavy drinkers. You may ask them to stop smoking, but are there any dietary interventions, and Pramod's done work on antioxidants and pain? Is there anything going forward in that area?
So if the patient wouldn't have come with a genetic report to me, I won't have tested them because they already have the end stage like disease, which you cannot modify except for palliative therapy for stones or pain. Had they come early on, yes, because they did not have any risk factor, and especially one of the brothers had pancreas divisum, genetic testing at the early stage would have been much more beneficial in those two brothers. So right now it's like palliative. I mean, it treat their symptoms, their complications, and lots of counseling. We have to talk to them, and I mean, that's the way to go.
I put some questions also to the speakers, and I think from the clinician side, which is very, very important, I think. So both of you started your presentation that you are not a geneticist. Although I think if in the room, you two have almost the biggest knowledge, in this field at what you were speaking about. Of course, Miklos is next to me. So, but, and it case. So, Vader, and I found in my practice, when there was the data and also in the law, geneticists needs to do that. And after the patients came to me with no understanding at all about the disease development, because the geneticists haven't seen even a single pancreatitic patient in their lives. So is it good that you two are out of the possibility to give information to the patients?
I don't use genetic counselors for I play one when I see my patients. But I think if we get into more complex testing, for instance, it may be important if you're going to do genomic or exome testing to involve somebody who's going to sit down and take the time to go through everything with the families, because often the sessions in the US anyway can be as long as an hour or more. So there's a lot of information that's imparted, but in practice, I will schedule those patients for a longer time period and spend time with them and answer their questions as best I can.
I agree to Dr. Low. Even with my patients, I do the main talking, explain them the pros and cons, and of course, if we have to do multi-panel genomic testing or they come with reports like this one that I showed, then we take the help of our clinical geneticists, because they will be in a better position to talk about the permutations and other aspects.
I totally agree with it, because I think this is very important to work together. But I mean, in a couple of countries, like I know, like in Hungary, it's very strict that they have to do the concession, which I think maybe it's not the best way. My other question is about, Mark, you mentioned that currently who to test, and you mentioned that we should test the idiopathic pancreatitic patients and not those who we know actually the etiology. However, for example, and in some cases in pediatric part, you showed around 50–60% of the possibility to find genetic alterations. But for example, like Andrea Parnitsky's and Balázs Németh Apple study, what I learned actually is that even those kids who has different kind of etiological factors, there is also a high probability to get a mutation. So for example, in the pediatric population, should we test only the idiopathic ones, or just look at the other possibilities as well?
Well, I think in the research, most of those patients should be in a research setting. I think it depends. So you pointed out that there are some the patients who develop symptoms and also have pancreatitis tend to have genetic risk factors. And so that may help in decision-making and now. So there are some instances where the knowledge of a genetic risk factor may be important. That's less clear in children. Just pancreatitis alone seems to be an independent risk factor in kids. But I think that there will be more instances where we understand the environmental impacts. I think the point is that until we have, and as I think Marcus Lurch said this yesterday, and so we know that in the adult world, if somebody has a genetic risk factor and drinks a lot of alcohol, that just cutting out the alcohol consumption will make a big difference in their clinical course. And we don't know, or we don't have a therapy for the genetic part of it. So does it help you to know what that is beyond a research environment?
Yeah, just I tell you know a very interesting case that we have an 18-year-old patient. It's the pediatrician see them, and the patient had CFTR and SPINK mutation, CTRC and SPINK mutation as well, had plenty of recidive attacks, and were thinking about to have a total pancreatectomy and so on this case. However, for example, finally, she was just before finishing the graduating schools, and they decided no, not to do the operation, but the kid said, okay, but no, I realized, and she admitted that she had sometimes alcohol consumption, during the other kids' parties, but no, knowing, that she has this, she stopped, and she is not taking any kind of attempt to have it. And after that, after this period, the disease didn't come back for her. So, for example, there is a clear case like this one, that even, for example, in this case, okay, has some small, but maybe one glass of alcohol. They are not alcoholics, for sure, but it could be a very important message for them. Of course, if somebody an alcoholic and 40-year-old and drinking, that's I understand. But for in pediatric field, I'm not 100% sure that we should test only the idiopathic, but maybe I am not a pediatrician, so I don't know.
I think it depends on clinical practice. I mean, I'm not sure that would matter. I tell all of my patients that they shouldn't smoke or drink.
Yeah. I think this is an example of the gene-environment interaction. Take care of the environmental factor. In this patient, I think even if they take a little amount of alcohol, that will sensitize because they already have the risk factors in the altered genes. I think.
Thank you, Peter. Very interesting discussion and panel. Thank you for helping us to understand genetics in pancreatitis and bringing also the clinical relevance to it. I have a very abstract question, and this is related also to other diseases where, polymorphisms or risk alleles that exist in other inflammatory diseases. I wonder, most of the, at least the ones that I know and that I can try to understand are in the initiation or in acinar cells or duct cells, these SPINK, PSSR1 type of mutations, etc., including CFTR. Do you think there are immune polymorphisms or mutations? Have they been identified? Is it because, or do you think they don't have any relevance in pancreatitis, or we haven't looked in the right, maybe this is a heterogeneous population and we haven't found them? I don't know. Could you say something about that?
I think this is a very pertinent question. So if you take the example of the two brothers, one of the patients was not having pain. Of course, he had the disease morphological change. We do see many patients of chronic pancreatitis who twins or familial pancreatitis, the similar kind of genetic polymorphism, but the disease morphology is different. One of them will have very severe disease, other will have very mild disease. So there is a possibility, I believe, either in the immune mechanism, as you rightly suggested, that could modulate the disease progression or the disease severity. What is your take on that?
I think the most convincing evidence that immunology has nothing to do with this are the unbiased GWAS studies. So in those studies, nothing came up so far. Now, of course, they always recalibrate those studies, setting different threshold, and then so this may change in the future. And Dave Whitcomb has a paper which came out maybe a few weeks ago where they claim that there's an immunological locus which might have something to do with pancreatitis. So these do pop up on the radar, but the biggest GWAS studies didn't show any immunological loci so far. Now, what Rup mentioned here is that severity may be modified, but again, studies are not convincing. There are a few smaller studies which show some polymorphisms affecting severity. So, but that hasn't been actually studied enough, right? In bigger cohorts.
Yeah. Thank you. I think the TCR sequencing in BOMI's data is what I was thinking in those hereditary, because there were some TCR epitopes that seem to, even though we didn't look at the HLA, but I think you're right. Maybe you already have the hereditary pancreatitis already, and then you have on top of that, maybe, as you said, in some cases it gets accelerated because you have those immune or something that I guess we need to look into.
No, also, what we forget often that when you do genetic association studies, first thing you have to do is define the phenotype. And usually the phenotype is pancreatitis, chronic pancreatitis, very generic. And many of those things may come up if you start defining endophenotypes, very specific things, right? You say, I'm going to look at people who have fatty replacement in their end-stage disease. That may be a very, very specific subgroup. And then you do your genetic analysis. Now, this is, of course, limited by the fact that we don't have enough patients. So you come from IBD when you think big, where there's probably 10, 24 more patients available for this kind of studies. So you can define, different phenotypes. We try with alcohol and smoking to restrict subgroups and analyze them separately in genetics, but beyond that, there's very few, subgroup analysis in genetic studies, which again, maybe will change in the future.
Thank you.
I still would like to challenge about with a couple of cases the speakers. So it was clear from the presentation that we should test the idiopathic, either recurrent acute pancreatitis patients or the idiopathic chronic pancreatitis patients, but sometimes they can mix up with environmental factors. So for example, I have a patient who's 32-year-old, came to my ambulance, and it was an acute pancreatitis, but already had some Wirsung dilatation, and it's turned that it's a chronic pancreatitis, and he was alcoholic. He admitted his GGT level were around 400, and it was very clear the etiological factor. But he was very committed to change his life, and he stopped drinking totally. And this was also checked, by the biochemical parameters that he stopped. But the recidive pancreatitis still came back on an idiopathic base that he received. So should we test this young adult about whether this patient has any genetic alteration?
Yeah, I think that that's a patient where you should give strong consideration to testing, and have that discussion with them. And if they're interested in having testing done, go ahead with it. It will provide you a little bit of information on potential etiology, and you've taken away the one risk factor that you know about. But that's, once again, that knowledge is mostly for counseling and moving forward, and not yet therapy. So that's the discussion that you need to have with the patient.
My other question with the counseling, because I tried to look at the literature also before this session to find evidence that those patients who that counseling versus those who doesn't, whether in a future perspective, can we reach maybe a beneficial effect from the patients that they know that they have genetic alterations. They became to be more defending themselves with food, drinks, and so on or not. So is there any evidence in the literature that if you tell to the patients and they change their lifestyle, because we saw that both environmental and genetic factors can play a role. For example, this girl I just mentioned, you know, who absolutely stopped drinking. Is there any evidence in a clinical field that counseling and after the counseling changing the lifestyle will have causing less acute episodes?
So I think there was a paper in gastroenterology several years back in alcoholic patients. If you counsel, the recurrence of pancreatitis comes on, but I'm not sure if there is any study on the similar lines based on the genetics. But I don't think that study considered a genetic aspect. Those are alcoholic pancreatitis. And if you're counseled to stop, they definitely have the reduction in the recurrence.
Yeah, I don't know of any sort of similar studies or studies that you're describing in pediatrics, and I'm sure you're aware of that, that sort of counseling. And you mentioned consent. I think consent is important in the setting of doing the whole exome or whole genomic sequencing, not as much in the setting of doing a panel, for instance, or single gene therapy. I think you need to have a discussion with the patient and family. But there are, as I pointed out, there are a number of issues that can come up and when you do exome and genomic sequencing that don't have anything to do with analysis of genes that might increase risk for pancreatitis.
You know, this conversation started me thinking, one about sort of gene environment interactions and thinking about those twins that you presented. And when I think about environment, we always just say, well, it's alcohol and tobacco. That's the environment we have to worry about. But there must be more than that. And so I was wondering what you all think as non-alcohol, non-tobacco, environmental, contributors in these folks with, let's say, underlying genetic disease, or maybe not. So is it diet? Is it microbiome? Is it the status of immune activation? What are the other areas that we should be looking at that we have not yet looked at?
It's a great question, Dr. Forsmark. Yes, of course, there are issues beyond alcohol and smoke. And in India, smokeless tobacco is also used by several people. One definitely could be pancreas divisum or any other ductal abnormality of the duct. And regarding microbiome, we are currently working on the microbial aspects of chronic pancreatitis and how it interacts with the progression of the disease, endocrine dysfunction. So there could be factors from the microbiome, from some metabolomic changes that may interact with genetic changes. We don't know as yet, but it's an important food for thought, and we are anticipating such a study in the near future. So, but what you said is definitely correct. There could be beyond risk factor beyond alcohol and smoking.
I can't stop asking. I would like to ask about a little bit about the future and ethical issues, because sometimes I had patients as well when I had a negative effect of the counseling, because we did the genetic testing and it was negative. And we told to the patients that you don't have currently known genetic risk. And he said, oh, wow, that's brilliant. And they went out, so now I can start drinking or whatever, because genetically I am free and there is no problem. And after came back again, these patients with another episode of acute pancreatitis. So I can feel danger as well when you tell to patients it's that it's a negative. The genetic testing. I thought a lot what kind of randomized clinical trial we may thinking about to perform, whether to tell what patients that one group would get the information and the other wouldn't. And I have several ethical questions, whether would us be allowed not to tell the patients, for example, to run ethically a clinical trial when you make the genetic testing for a patient maybe in an environment, and after one group would know either the negative or positive results, and the other wouldn't know the negative positive results, because currently we don't have therapy. Would it be ethical to run such a study? You are in an ethical board and you receive a study which can tell you exactly whether the patients get benefits or not. Would you allow this study to run?
I think one could make an argument that you could run a study like that. Since you're not, you would have to set it up so that the counseling not to do known risk factors is the same, but I think, that would require some discussion.
But would there be a risk that patient might come up with a lawsuit later on of not knowing the results? I mean, we cannot do anything, but still they have the right to know their reports.
And the
So-
other aspect of that is, so they have a PRSS1 R122H mutation.
Of course, there could be expectation, if they have, yeah.
Oops, I'm sorry, you'd have to have that, what I said, if you have a patient that pops up with an autosomal dominant mutation, I think it would be unethical to withhold that information and have a discussion about reproduction and with that patient. So you'd have to design it the right way.
Robert.
Hi, thank you. I just wonder if I could comment on that very last discussion point, and wonder if it would be better, before considering such a trial, that the data, such as they are, be examined for the effect of identifiable and to a certain extent quantifiable lifestyle factors might have on the course of recurrent pancreatitis or chronic pancreatitis in patients who have an identified mutation and in patients who have no identified mutation, before contemplating that trial. The reason I suggest that is because certainly in most practices where there's a commitment to chronic pancreatitis in the UK, and certainly in our own in Liverpool, we would not give any indication to any patient who had either a genetic mutation or not with non-alcoholic chronic pancreatitis, and obviously the same with alcoholic chronic pancreatitis, that they have any license whatsoever under any circumstance not to modify their lifestyle if it's appropriate. And the advice would be that it doesn't matter whether they have a genetic mutation or not. Clearly, you can mount an argument to a patient that if they have a CFTR mutation, that there is a categorical evidence that they shouldn't drink alcohol. But nevertheless, just the fact that they have recurrent pancreatitis or chronic pancreatitis, to me, is sufficient evidence that they should not. And I don't think that if they have a no genetic mutation identifiable, they should be given any conceptual freedom to entertain the idea that they are free to indulge in anything. They have to, unfortunately, modify their lives.
Yeah, this is why is it, I think, a really, really important question, and I completely agree with you that somehow we have to get more evidences about how to help, how not to harm. And I think this is very, very important in genetic counseling, and we need evidences. This is why was my question. We need evidences to know that.
I agree.
So, Miklós, I really enjoyed this conversation from the clinical side. You have much more knowledge also from the genetic part, but I think there are lots of things to do, even if we cannot modify plenty of things in the genetic field. But I think there are plenty of studies are needed to continue this field. So we cannot go back and, okay, no, we know the most important genes involved, and no, there is no more time or no more importance for research.
Absolutely right. I think we did not discuss one major aspect, that all the genetics gives indications what to study. Because if you see genetic changes in a disease, that tells you that something's wrong there. And then I think as basic researchers, translational researchers, we really have to focus on these genetic clues. And I think with this, we can conclude this is very interesting and, you know, exciting session. And I think we have a break coming up and then we continue. Thank you.
Yeah, thank you very much.